So I think I'll get started and people can, continue to log in perhaps. Um, but I think we have a lot of people here and we'll want to get started on time. Um, so thank you guys all for joining us today. We're really excited to have you here for Schizophrenia 101. My name is Parzad. I work for the Harvard Brain Science Initiative. And it's really a pleasure for HBI to be hosting today's speaker, Dr. Joshua Roffman. Dr. Roffman works at Mass General Hospital. He is a psychiatrist and also a neuroscientist. And he studies a topic that I think is of great interest to many people in our community. I know that I personally am very fascinated by it, which is trying to figure out the biological underpinnings of mental illness. And he's particularly interested in serious mental illness, such as schizophrenia. He is an expert in schizophrenia and in trying to think about interventions using a variety of techniques, multimodal brain imaging studies, genomics analyses, and just conducting clinical trials. He and his team have shown the neuroprotective effects of folic acid in schizophrenia and just in normal healthy brain development as well. And from some of those studies, I think it's given interest in launching an initiative. And so there's a new mass early brain development initiative that he is directing. And they are thinking about ways to look at during prenatal times and also early life, what are the factors that are neuroprotective? What are things that could help reduce the risk for schizophrenia and other mental health conditions? Dr. Roffman also co-leads the hospital-wide neurosciences initiative at Mass General, and that's actually how I had the fortune to meet him. So he did his undergrad here in Massachusetts in Amherst College, and then he went to the University of Maryland and NIH for his medical degree, and then he came to MGH for his postdoctoral work and his residency. In addition to all the titles I just told you about, he also co-directs the Division of Psychiatric Neuroimaging at MGH. So thank you so much, Dr. Roffman, for joining us. We're really excited to have you. And for those who are new to our 101 series, I just wanted to explain the format. So the speaker gives about an hour talk, and during that time, if you have questions, feel free to just jot them down in the chat box, and you can put them to everyone. It doesn't have to be just to the host. And then at the end, you can raise your hand, and we can alternate between video questions and chat box. If you took the time to send a question in beforehand, thank you so much. We have all of them. Dr. Roffman has incorporated some of the answers into this presentation. Some of them we can read out, but if we haven't addressed your question, feel free, please, to type it in or raise your hand. And with that, I think we'll get started.
Thanks so much, Farazad. It's great to be here at HBI. Which is a fantastic group. I see some friends in the audience, which is terrific. Really grateful to have this opportunity to speak with all of you. So thank you again for the invitation. And indeed, I must say the questions that came in ahead of time are fantastic and manifold. I wish I could say that they will all be answered by the end of the talk, but I guarantee they won't. Not only because, well, there are a lot of them, but more importantly, there are more questions than answers, I think, at this point when it comes to the neurobiology of schizophrenia, which is why it continues to be one of the most debilitating, disabling, chronic problems that we see in all of psychiatry. That being said, I think it is an exciting time. Parzad and I were just chatting a minute ago about, the unexpected, I think, transformational change in psychiatry that has just happened this year with the challenges that COVID and the pandemic have posed. It's amazing to see how quickly something fundamental in the practice of psychiatry, which is a clinician and a patient sitting together in a room, can change in ways that result in even improved outcomes. As we have now transitioned into a completely virtual specialty. Now, I would doubt that we will see changes in schizophrenia that will occur with that speed. In fact, I can pretty much guarantee it. But I think it is an example of how things really can change. And again, one of many reasons why I'm optimistic that over the course of, for people who are just coming into the field, I think that the practice of psychiatry, and in particular, treatment and perhaps prevention of chronic mental illnesses like schizophrenia will change over the course of their careers. So with that, let me share my screen. And let's see. Okay. Can you all see the title slide? Great. Okay. And then, as Parazad said, would love to have questions come in during the talk. It might make the most sense, kind of given the format, to go through the talk, and then we will have plenty of time at the end to get to as many of these questions as we can. They really were fantastic questions. I hope that we can get to as many of them as possible. Here are my disclosures. So divided this up into four pieces. The first, for those of you in the audience who are not clinicians or who have not had personal family experience with schizophrenia, I wanted to give you a sense of how we think of schizophrenia in psychiatry, both in terms of the diagnostic criteria, but I think more importantly, the experience of patients who have schizophrenia. Give you a sense of what we have at this point for treatment. And I think, again, most importantly, to give you a sense of what's left to do, which is quite a bit. One of the things that attracted me to schizophrenia research, frankly, is that the need is have available at this point for treatment. So then we'll take a step back and think about how this happens in the first place. Oh, sorry about the typo. It's some organizing theories and controversies. Then we'll get into a few examples of how neurobiology can help us solve some of these clinical problems. And then end with a little bit of a cautionary tale, I think, but also, again, an opportunity to talk about why this is an exciting time and how it really will take a village to continue to make progress in treating and preventing this disorder. So just again, to take a step back, in some ways, schizophrenia is a prototype for serious mental illness in that it hits pretty much all of these characteristics that, again, we see across other things, bipolar, depression, OCD, et cetera. So psychiatric disorders as a whole are common with a lifetime prevalence of, about half the population at some point during their lifetime will develop a psychiatric disorder. They emerge early in life. 3/4 of patients who will ultimately have a diagnosis of any serious mental illness will have symptoms, if not a diagnosis, by age 24. They are comorbid. Those who have severe mental illnesses are also likely not only to have other mental health problems, but also physical health problems as well that can be life-limiting. They are incompletely treated, which is really an understatement. Only a tiny fraction of people who have schizophrenia and other serious mental illnesses are actually getting state-of-the-art treatment. And of course, they are costly. And schizophrenia in particular, but again, any of the common psychiatric serious mental illnesses comprise a disproportionate, I think, amount of global morbidity and to some extent mortality. So again, just to underscore how mental illnesses are illnesses of young people, this is a figure that I like from a paper in Lancet from a few years ago. And it's complicated, but really the most impressive thing, I think, hopefully is staring you right in the face, which is the color red. So the x-axis here is age of onset. The y-axis is years lost to disability, which is a standard public health index of how disabling a disorder can be. And you see a lot of red, and that's true for males and females. And the amount of red diminishes proportionally as the population ages, but not absolutely, right? It's only because other disorders that tend to emerge later in adulthood are also coming into play. But I think that the key thing here, and what I took away, is how early it starts. So by age 5, mental and behavioral disorders are the #1 cause of disability, starting at age 5. Even though what we think of as things like schizophrenia, depression, bipolar tend to emerge later in life, in the second or third decade of life. This is when it starts in terms of symptoms. So what is schizophrenia? So in our diagnostic Bible, for better or worse, in psychiatry is the DSM. And as with pretty much all DSM diagnoses, it is the Chinese menu is the analogy that people use sometimes. It's a little bit of this, a little bit of that. The cardinal features are 2 or more of delusions, which are fixed false beliefs, like paranoid ideas. The FBI is after me. Aliens have implanted microchips in my brain. But by the way, there's a difference between those two. The FBI following me, that actually could be happening. Aliens implanting microchips in our brain, as far as we know, doesn't happen. And so we call that a bizarre delusion because it's not something that we know can happen in real life, as opposed to the other delusion, which is a non-bizarre delusion. And with non-bizarre delusions, you better make sure that it's really a delusion. And sometimes it's not. But in schizophrenia, you tend to see more of the bizarre delusions that can't happen in life, as far as we know. Hallucination. So this is a sensory stimulus, be it auditory, visual, taste, smell, touch, that the patient experiences without there actually being any physical cause of that stimulus. So auditory hallucinations are, again, the cardinal one in schizophrenia, and you'll hear more about that in a moment. Disorganized speech. So when people are in the throes of illness, they can be very difficult to understand what they're saying. In extreme cases is word salad. It just, it has no structure to it. That's only the case some of the time for people who have this kind of illness, but once you'll see it, you'll never forget it. Grossly disorganized or catatonic behavior. So people who, again, are in the throes of this have a very difficult time with just regular activities of daily life, getting dressed, eating, sleeping. And you can imagine how difficult it makes it to be able to have a job, for example, when you have this going on. And then, the first 4 tend to be the more dramatic symptoms that people who aren't as well-versed in schizophrenia still tend to know about. But negative symptoms are unfortunately even more problematic in terms of long-term disability. And these are ones that get less attention. They're less dramatic. So this is flat affect. Alogia, again, is a speech, impoverished speech. Avolition is basically the lack of motivation. So, someone who has an illness like this may not have the desire to go get a job, even though that is what's needed in order to, pay the rent, for example. So as with all major psychiatric illnesses, the symptoms must be bad enough to be problematic. So significant social occupational dysfunction. There's a time piece, again, as there is with all psychiatric disorders, where you have to have had at least some of these signs continuously for at least 6 months. There are some rule outs. So schizoaffective disorder is a very closely related diagnosis, where in addition to psychotic symptoms, there are also prominent affective symptoms like depression or bipolar. And by the way to differentiate that from a primary mood disorder like depression or bipolar disorder is, when do the psychotic symptoms happen relative to the mood symptoms? So if they only happen during mood episodes of mania or depression, and they don't happen in between those episodes, then it's a primary mood disorder with an overlay of psychotic symptoms. But if you have psychotic symptoms that also occur between episodes of depression or mania, then we think of it as a primary psychotic disorder with mood symptoms that are secondary. Now, as with everything in the DSM, this is purely based on phenomenology. It is not based on biology. And one thing that I think we'll see over the course of the talk as a theme is that the brain does not respect DSM criteria. And there is clearly important biological overlap across conditions that we think of as clinically discrete entities. Rule out medical etiology, again, is something that you need to do before really making any kind of a psychiatric diagnosis. I won't dwell too much on that now, other than to say that if you have a first episode of psychosis, it definitely deserves a full medical workup for non-psychiatric causes. And then this one just has to do with the comorbidity with autism, which I won't dwell on. Okay, so that's in theory. What about in practice? So I have two brief presentations for you. One is audio only. And I'm not going to play the whole thing. I'm going to skip around a little bit. But this was a simulation that was created based on the experience of people who have schizophrenia and who are suffering from auditory hallucination. So just we'll listen to a bit.
So stupid. Look at you. No, you can't. Stupid. Things on the other side of the road. The cars are coming. The cars are coming. Jump now. Jump in front of the car. Go on. Do it. Concept of professional needing function and money to be independent and wealth generation for extension of function.
Okay, so I think you get the idea. These are scary. People who are in the throes of psychosis, especially first episode, are terrified. I mean, as I think anybody would be if that's what they were experiencing. So, these are not pleasant. Frequently, the voices, and there are usually multiple of them, are saying derogatory things about the patient, or they're having a conversation with each other about the patient. Sometimes it's really difficult to discriminate individual voices. Just as a total sensory overload, you can imagine how distressing this is. So when you think about hallucinations and, again, delusions, these are the positive symptoms of schizophrenia, the ones that, I think more people know about. But this next case will give you an example of some of the other pieces of schizophrenia, which, again, are even more debilitating. Let's see if I can advance this. Yep.
My name's Bob, and I'm Nick's adoptive father. We went through a lot of traumatic times. His mother died when he was 16, and when she died, he suddenly started getting all sorts of different reactions. He started throwing things and smashing things and smelling things.
The shock was that I woke up the one day and there was a doctor looking over me in the bed. Shortly after that, there was ambulance men there. I was not expecting anything like a mental hospital.
Nick does have his moods, and he can get very angry. There was one case when, about 2 o'clock in the morning, Bing went on my phone. I woke and read it. It was just one word from him: murderer.
I've taken so many different medications, and it gets me confused. Is any of the medication making me in a different way, in a different mood? I do have that paranoia in myself. What do people think of me? Do they think I'm acting different to other people? I haven't got that fixed routine, if you know what I mean. So I sort of take every day as it comes. The only thing I'm doing that is structural is football every week. But I enjoy it, and it helps me with my, my physical state and my mental state, really.
It is very stressful having to cope with him. It's very expensive too, because he never has money. So I'm always having to bail him out. I wonder what's going to happen to him when I'm no longer able to cope.
I gotta be honest to you, I don't think I was ever schizophrenic. I just don't believe it. It's in a stage where I think back and I'm thinking, well, my mates are married, they got kids, they got jobs, and there I am still in the same position. I don't really know what to make of it sometimes.
Okay, so I think that case, tells you a lot. I mean, first of all, taking a step back again, it really is a tragic illness. The last pieces of what he said, I think, in some ways are the most resonant. But you get a sense of this is someone who needs caretaking in order to be able to provide or have access to the fundamentals of life. In addition to that, though, clearly there's the paranoia, there's the lack of insight, right? I don't think I have schizophrenia, but he does have schizophrenia. The medications, the struggle with medications. Should I take this? Imagine, someone who's paranoid about taking medications. That makes it that much more difficult. The mood component. In his case, the violence piece, and that is something that would be a whole other talk. I think the bottom line is that when people are in the throes of psychosis, you have to be concerned about violence. And at the same time, as with all mental illnesses, people who have schizophrenia are much more likely to be the victims of violence than they are to be the perpetrators. So again, that's a whole other talk, but that is part of the experience. And then the other, interesting piece there is the onset, right? So age 16, that's about right. And in the context of a significant life stressor, in this case, his mother died, not at all unusual to hear cases of emergent schizophrenia, related to a specific stressor like that, or a less specific one, like going to college or joining the military, going through basic training. This is when things start to emerge, because as you make that transition from adolescence into adulthood, it just comes with a whole set of stressors that the brain is not well set up to manage if you have schizophrenia. Okay, so a whole range of symptoms, positive symptoms, negative symptoms. Which ones are the most important? Well, for one, the negative symptoms, unfortunately, as you can see by the strength of the arrow there, contribute more and related cognitive deficits to social occupational impairment, et cetera. And unfortunately, every antipsychotic medication that we have has some efficacy against positive symptoms and nothing with regard to negative symptoms or cognitive impairment. We have no good treatments for negative symptoms, which again are the most debilitating. So hopefully this makes clear the need. So in terms of just some other kind of population numbers, it's about a 1%, maybe a little bit less than that, prevalence worldwide. It doesn't differ that much from country to country. It's more common in men who also have earlier age of onset. Those are the mean ages. Peak in late adolescence, early adulthood. Here's a clue to etiology: 10-fold increase in risk for first-degree relatives. Again, before the modern era of molecular genetics, what we had were family studies to show just how strongly schizophrenia runs in families, which clearly it does. So what does the course look like? Time here is kind of on the x-axis. And for people who ultimately get schizophrenia, this is what it can look like. They have a premorbid period, say during childhood and adolescence, where things may just be a little bit off in terms of social relationships, academic performance. Then you get into this prodromal period, think, teenage years, where grades begin to decline, friendships begin to deteriorate. There's more isolation. You often see marijuana use. Obviously, in this age, you see a lot of marijuana use anyway. It just so happens to be that in psychosis, you tend to see a lot of it. It is way more typical than not to have a first break patient who has a history of cannabis use, if not abuse. And then, you cross the line into expressing these actively psychotic symptoms, positive symptoms, hallucinations, delusions, et cetera. And the course tends to wax and wane basically throughout adulthood. There are some people who start to express these symptoms who don't have the same long-term outlook. And there are some who, despite expressing symptoms like this, which are, relatively non-specific during adolescence, who definitely don't go on to have schizophrenia. But they do go on at a much likelier rate than otherwise to have other categories of mental illness. Okay, so a brief word on treatment. So we've known for decades now that the D2 receptor is likely involved in schizophrenia because all antipsychotics target the D2 receptor. This is kind of the classic chart showing the relationship between D2 binding potential and the dose, relative dose that you need in order to achieve an effect. All of these are the older first generation antipsychotics: Haldol, haloperidol, chlorpromazine, thorazine. So they're all on here. And then in the 80s and 90s, the industry started to develop another series of antipsychotics called the second generation antipsychotics, with the hope that they might be more effective than the first generation antipsychotics, both for positive and negative symptoms and related cognition, and do better in terms of side effect profile. So as you might imagine, for those who know much about dopamine pathways in the brain, if you block D2 signaling and you're giving it by a pill, which is a systemic administration, you're going to block every dopamine pathway. And in particular, with regard to off-target effects here, are Parkinsonian symptoms. So what happens in Parkinson's disease, you lose dopaminergic neurons in the substantia nigra. And here you are pharmacologically doing something very similar by blocking the D2 receptors. So extrapyramidal problems, tremor, tardive dyskinesia, which is a kind of facial and arm and leg tic that you see sometimes in people who are taking chronic first generation antipsychotics. These were very common. And it was pretty much the case that before the second generation antipsychotics came online, you could kind of go on the bus and see if somebody was taking first generation antipsychotics, because you could just tell based on these abnormal movements that they had. So second generation antipsychotics, the first one was clozapine, which continues to be the one that we think of as the most potent. Also can have the worst side effect profile in that it can cause a life-threatening condition called agranulocytosis. Other ones you may have heard of: risperidone, olanzapine, aripiprazole, ziprasidone. So they all work just as well as the first generation antipsychotics with regard to treating positive symptoms, but unfortunately, they don't do any better in terms of treating negative symptoms. They don't do any better in terms of cognitive impairment. And they have their own side effect profile, which is in some ways worse, unfortunately. Again, you may have heard of some of these, but basically metabolic syndrome, hypertension, diabetes, cardiovascular disease. There is no question that that taking the second generation antipsychotics puts you at increase, some more so than others. But not an atypical story to have somebody who was a first episode, they get put on olanzapine, and within a few months, they have a 20 or 30 pound gain in weight. So their symptoms improve, but now they've got a new problem. So what's the upshot with regard to public health? So 41, but now perhaps higher, these numbers are from a while ago now, of schizophrenia patients have this metabolic syndrome. Add to that the fact that 3/4 of patients with schizophrenia smoke. They have less access to primary care. They're less compliant with treatment. What you get is a 20% shortened lifespan, which is just staggering if you think about the total cost of this disorder. You have a twofold increase in premature death due to cardiovascular disease. So that's where we are. We have treatments. They work for some symptoms. They have pretty disabling side effects. And unfortunately, people who have schizophrenia, and this is roughly 1% of the population, have a chronic illness that poses enormous constraints for patients, for their families, and for society at large. So that's what drew me to schizophrenia. There is so much need. In particular, what attracted me to psychiatric neuroscience was the potential for some of these tools to make a dent, which, hopefully, as I mentioned at the beginning, we're starting to make some progress. Okay, so let's now transition to more of the neuroscience part of the talk and think about some organizing theories of the disease, of which there are many. None of them, I would say at this point, is particularly dominant. Some, they've kind of waxed and waned. Some of them are now more in vogue than others. But the bottom line is these are all theories but none of them by themselves gives us a complete answer in terms of what causes schizophrenia. Okay, so I'm going to talk about three of these kind of theories and related controversies. So the first one, and the one where I think we've actually made the most progress at this point, is a question of whether schizophrenia is a neurodevelopmental disorder or a neurodegenerative disorder. So the idea of a neurodegenerative disorder comes from the late 19th and early 20th century, in observations of clinicians who had patients with what we now know as schizophrenia. So this term dementia praecox was developed by Kraepelin and used by others like Bleuler to describe what they believed to be the underlying brain process, which was an early dementia. So dementia, you think, is a neurodegenerative process. And they said that because symptoms kind of take hold in early adulthood and are associated with cognitive impairment. Now, note that I didn't say cognitive decline, because that really isn't part of the spectrum, which was kind of the first hint that maybe it wasn't a neurodegenerative disorder after all. Bleuler also made described the syndrome as schizophrenias plural. And I think, and that relates to some of the questions that we got, I think that that's fair given the extreme clinical heterogeneity of the disorder. And again, we're talking plus or minus affective symptoms, varying degrees of cognitive symptoms, different types of hallucinations, different types of delusions. It's really a very broad syndrome. And even 100 years ago, there was this question of, is there a single underlying biology of this disease, or is it multiple biologies that ultimately express themselves as multiple illnesses? This is one of the first famous papers by Danny Weinberger, who's one of the giants in the field, who I had the privilege of training with during medical school. And this was just at the early days of neuroimaging. And so while in general, I would say there is a fairly striking disconnect between the lack of gross neuropathology and the severity of symptoms in schizophrenia, one thing that has emerged pretty consistently is enlarged ventricles. And in this paper and in subsequent work, there's this chicken and egg question: is it schizophrenia or is it the antipsychotic medications? And I think at this point, there's enough evidence to really say it's at least partially related to schizophrenia. And again, enlarged ventricles, that's something we think of as typically associated with neurodegenerative processes like Alzheimer's disease. But I think the field is now pretty squarely pointed in the other direction, which is neurodevelopment. So I'm going to give you a couple of the numerous lines of evidence which now support that idea. So now, in the age of MRI, we have a much better understanding of the brain as a dynamic organ and what changes in the brain over the course of adolescence in the years that precede, typical onset for schizophrenia. And so one thing that we see very reliably is that there is an age-related thinning of the cerebral cortex. It starts in more posterior and medial regions, and then there are waves of thinning over adolescence that make their way anteriorly and laterally. And it tends to be pretty linear as you start from teenage years going into young adulthood. So this is normal, and it's good. Presumably, it's what's helping our brain to mature, although the underlying mechanisms of that remain very much an open question. I'll come back to that in a few minutes to talk about one potential mechanism, which is synaptic pruning. So again, waves of thinning over the course of late childhood and adolescence. What happens in schizophrenia? And this is child onset schizophrenia, which are really extreme cases where there's higher genetic loading. But basically, we see this in all at-risk populations for psychosis. There is an early and accelerated process of cortical thinning. And then this persists into adulthood for people who have the disorder. There are, again, relatively subtle but widespread differences in cortical thickness in people who have schizophrenia versus people who don't. That being said, again, as with enlarged ventricles, this is by far not by far a specific syndrome, right? You can get accelerated thinning in a whole bunch of psychiatric disorders, not just schizophrenia. It just so happens that there's fairly robust evidence linking the two. And again, from a mechanistic standpoint, we're not really sure what's going on, although we do have some ideas. Okay, so these are other studies showing basically the same thing. This was from the Philadelphia neurodevelopmental cohort, which looked not at schizophrenia, but at the symptom of psychosis during adolescence. So these are, most of these kids are not going to go on to have schizophrenia, but it turns out that having psychotic symptoms that are sub-threshold definitely increases risk for schizophrenia. And it's actually not that uncommon in kids who are this age. But again, kids who have these symptoms tend to show early and accelerated patterns of thinning. They also show things like hippocampal volume differences and other subcortical changes. This actually is, I think, the only slide that I'm going to show of stuff that we've worked on, only because it's really kind of directly related to this idea. So Parazad mentioned that one of the things we're interested in is effects of exposure to folic acid during pregnancy on risk for psychiatric illness. As it turns out, there's a really exciting, robust, at this point, literature, not in schizophrenia so much, but in autism, showing in multiple large prospective studies, in different countries around the world, that women who take prenatal folic acid, which is recommended anyway for neural tube defect prevention, spina bifida prevention, women who start taking folic acid either before pregnancy or within the first 2 months of pregnancy, those kids go on to have half the risk of autism compared to the case where a mom starts taking prenatal folic acid and other prenatal vitamins in the 3rd month of pregnancy and afterwards. And that's pretty remarkable, actually, given that autism is a pretty serious illness. It's a common illness. And folic acid, we have no idea why it's doing this or, if it's doing it. Of course, could be an epiphenomenon. These are well-controlled studies. But, could it be a proxy for something else? We don't know. But whatever it is, it certainly has some impact. So what we looked at was, what's the effect of increased exposure to folic acid early in pregnancy on longitudinal brain development through adolescence? And what we saw was kind of interesting. Basically, we saw a delay in the thinning of the cortex. Again, this is not in a schizophrenia or non-schizophrenia population per se. But that effect would seem to oppose the effect that we see in schizophrenia. And in very preliminary analyses that also came out of the Philadelphia cohort that we worked with in collaboration for this, there is some signal suggesting that indeed that delaying in thinning has a bit of signal with respect to lower psychotic spectrum symptoms. Very preliminary, I would say, but promising. And again, I throw this in to illustrate how we think of these as neurodevelopmental disorders. Here's the other piece of evidence that also transitioned us into our second kind of big question, which is genes versus environment. So it turns out that risk for schizophrenia and several other serious mental illnesses can be relatively strongly influenced by certain early life exposures. Urbanicity, migration, stressful life events, and we're not just talking about stressful life events around the emergence of the illness, we're talking about early childhood adverse experiences. Cannabis use, I mentioned, that's a particularly interesting one, again, from a chicken and egg argument. This was a paper that came out a couple of years ago looking at whether polygenic risk for schizophrenia, which I'll define in a few moments more specifically, but basically this is what we know about one's genetic loading for schizophrenia. It's not only associated with increased risk for schizophrenia, it's also associated with increased risk for cannabis use. So is it genetic predisposition is actually influencing cannabis use, which is influencing the disease, or is it true unrelated? We don't know, but it's an interesting pattern. But also, one of the reasons why we're interested in prenatal folate is there's a ton of signal suggesting that prenatal insults can be important. So for example, replicated studies of populations who were exposed to famine show that 20 years or so after the famine is over, there's a transient doubling of schizophrenia incidence that then goes back to baseline, within a year or two. Which suggests that something about the condition of famine, and certainly there are numerous things, nutritional and otherwise, that are happening during famine that might be bad in terms of fetal exposures, but something's going on that substantially increases risk. So doubtless, the environment plays some important role. And then, the other thing here that I will quickly touch on, we can talk about it if there's interest and time, infection. So it turns out any kind of maternal infection increases risk for schizophrenia and potentially other disorders as well, even things like urinary tract infections, which is a little scary. What's a lot scary is the fact that we are now in a pandemic. And while to this point, there's very little evidence of direct transmission to the fetus, we don't think it gets through in most cases. There is for sure an inflammatory storm, which actors like IL-6 definitely cross the placenta and have been associated in previous studies with bad neurodevelopmental outcomes. So I think it's not anything to panic over, and there's not much we can do about it, but it is something we're going to need to keep an eye on from a public health perspective, long term, after the pandemic is over. And of course, the other thing is stress. And we know that maternal stress during pregnancy can also increase risk. None of these things by themselves are going to do it for sure. But you start adding them together and then, there's a recipe for trouble potentially. Okay, so we'll come back to that for discussion at the end because I imagine people may have some other thoughts about that. Okay, clearly it's not only environmental, right? So the heritability of schizophrenia is 80%. 80% of someone's chance of developing the illness has to do with your genetic makeup. And we've known that for a long time from these family studies. And now we're beginning to really operationalize that using modern large-scale genetic studies. And of course, other psychiatric disorders are also very strongly heritable as well. It's not 100%, right? That's where the environment comes in. But if you want to look for the biology of schizophrenia, this is a great place to look because we know it is so strongly heritable. So I'm sure this group, for the most part, is very familiar with these types of studies, so I'll very briefly describe them. So genome-wide association studies rely on large populations of cases and controls. You're looking at genetic variation across the entire genome and asking a question for a given single nucleotide polymorphism. Is there a difference in the frequency of one allele versus the other in the schizophrenia group versus the control group? So this, 10 years ago, when we only had 20,000 people in studies like this, there were 5 hits that were, statistically robust enough after you correct for multiple comparisons to be GWAS hits and, clearly associated with increased risk for schizophrenia. 3 years later, you've got 6 or 7 times as many participants, and now there's 108. And the latest version of this, PGC3 schizophrenia study, is now making its way through review, and now we're up to several hundred hits. So clearly we're making some progress, but there are some important caveats to how to interpret this. For one, it's clear, not surprisingly, that there is overlap in terms of genetic liability with other disorders. So this was a great paper that came out a couple of years ago in Science, looking at the overlap in genetic loading for a bunch of psychiatric disorders. And as you can see, schizophrenia overlaps with ADHD, anorexia, anxiety, autism, bipolar, depression, OCD. It's pretty remarkable. Not surprising, given that, if you have someone with a history of schizophrenia, there's almost a better chance of finding something like depression or bipolar disorder in their family history than there is schizophrenia. But now we kind of know why, right? There's some degree of genetic loading that really crosses disorders. Again, and even more evidence that the brain does not play the DSM game. Sorry, I'm just changing this so I can see the top here. Okay, so genes or environment, both, right? Must be both. But that leads us to a third area of controversy, the dopamine hypothesis, the glutamate hypothesis. Where does the dopamine hypothesis come from? Well, it comes directly from the fact that D2 receptor antagonists are decent treatments for psychosis, right? As we already saw, all antipsychotics, including the newer ones, by the way, all have D2 receptor antagonism as part of how they work. Furthermore, there are evidence from other types of studies. So anybody recognize this guy? So this is amphetamine. it turns out that people who are chronic amphetamine abusers can develop a syndrome that looks a whole lot like schizophrenia. And what does amphetamine do? It releases dopamine. People who are high on cocaine can have psychotic symptoms. Same deal, releases dopamine. So that's another piece of evidence potentially. And then, there's a whole litany at this point of PET studies showing changes in D2 receptor occupancy and other dopamine system related changes that I won't get into now in schizophrenia, including in unmedicated patients with schizophrenia, suggesting that there are abnormalities of dopamine signaling. So pretty consistent story, but there are some problems with this. First of all, notably, as I said, it only treats the positive symptoms, doesn't touch the negative symptoms. So there must be more complexity to the underlying biology than just an excess of subcortical dopamine signaling. In fact, there may be too little dopamine signaling happening in cortical regions, which may be something that's contributing to cognitive impairment. But there's another potential issue, or at least there was. So when this first GWAS came out in 2011, there weren't any dopamine hits. So people were like, wait a minute, could we have been wrong this whole time about the dopamine theory of schizophrenia because there aren't any dopamine-related GWAS variants? Well, give it time. So here was the 2014, and there's DRD2. The D2 receptor pops up right there. So that I think was reassuring to dopaminologists about its role in schizophrenia. But again, clearly, it's not the complete story. And by the way, the other way we know that is because there are clearly other neurochemical systems involved. So there's one dopamine hit, but there are 4 glutamate-related hits. And that goes along with, again, other information that we know from clinical stories. So anybody know what this guy is? Very different structure than dopamine. This is PCP. So what happens when you give someone PCP or ketamine? They become acutely psychotic if you give it at a high enough dose. Now, we're using ketamine all the time now in psychiatry to treat treatment-refractory depression. And for some people, it's like a miracle drug. But we're not giving it at doses that cause psychosis. It's getting given at much, much lower doses than that. But the syndrome that we see in people who are using PCP, using ketamine as a street drug, looks a bit more like schizophrenia, actually, in that you can have both positive symptoms and negative symptoms. But again, it's not dopamine or glutamate. It's probably dopamine and glutamate and a number of other systems. Okay, there are other controversies in terms of primary cortical areas versus secondary cortical areas, and we again could give a whole talk about each of these, and I think I'll just hold off for the sake of moving forward. But just to give you a sense of what some of the larger controversies in the field are, and that we're certainly not resolved on most of them. Okay, so how do we solve some of these questions? And we've already touched on a lot of these points. Epidemiology, those famine studies that I mentioned. Psychopharmacology with a caveat. Another good example that I like to give, which is one that my friend Eric Moreau suggested to me during residency training a long time ago. Eric is now doing great work in autism at Brown, is that if you give someone a diuretic, it's a great treatment for heart failure. So where do diuretics act? They act on the kidneys. They act downstream of the heart, and they just help flush the system forward. But they don't do as much directly on the heart as other classes of medications do. And yet they're effective treatments. So just because someone gets better with an antipsychotic does not mean that you can deduct D2 receptor abnormalities as being causal. So that's the important caveat. Postmortem studies, I'll show you a couple of those in an example in a moment. Brain imaging, again, I've showed you a couple and I'll give you a couple more. Genomics, and then we'll wrap up this part of the talk with some really nice stories from translational neuroscience. Okay, so David Lewis and his group at Pitt have been the real, one of many leading groups in this area of postmortem studies in schizophrenia. The caveat, of course, is that you have a brain that was exposed to a lifetime of psychosis, a lifetime of medications, a lifetime of all of the psychosocial things that go along with schizophrenia. which doubtless have their own neurologic correlates, and yet there, are the makings of some consistent signals. And this is actually now an incomplete model. I think this one's about 10 years old, of all of the various relatively subtle but consistent things that have been seen in postmortem studies of schizophrenia. Like, for example, there are differences in neuropil in pyramidal neurons. There are differences in parvalbumin GABAergic interneurons, which show reductions in GAD67 mRNA expression. Again, that's another glutamate marker. So, a whole bunch of these at this point, which are, piecing together a story of what may be happening on the level of cellular biology in schizophrenia. And since we can't access this in vivo, this is one way that we can learn something. The other, real boon in the last few years has been these gene expression studies, that look at, genome-wide gene expression across all sorts of, cortical and subcortical regions in people who have, schizophrenia, bipolar, other disorders. This happens to be a study that just looks at healthy individuals. Well, they're not healthy because they're dead, but people who did not have schizophrenia during their lifetimes or bipolar disorder during their lifetimes, and looking at the expression of genes at different points during the lifespan. So here, for schizophrenia, what you see is an enhancement of expression of schizophrenia-linked genes, interestingly, in fetal life. So these are, fetal demise brain tissue that were used to get these mRNA data. And then interestingly, there's a switch. Once you get into childhood, you see that these same genes are now showing less expression as a whole. And this, of course, is super generalized, but just to give you an idea of the overall patterns that we can pull out. Where interestingly, if you look at bipolar genes, there's a whole lot less actually happening prenatally. And there is, again, something happening in a similar direction as schizophrenia during early and late childhood. So what we're beginning to get is, when you put these studies together, diagnostic specificity, spatial specificity. I didn't tell you where we were looking in the brain, and this paper actually looked at several regions of the brain. I think this is prefrontal cortex, but also temporal specificity, because we have to think in 4 dimensions, right? This is a neurodevelopmental process for sure, and things are changing over time. Okay. Imaging, just a couple of other, there have been thousands and thousands of imaging studies in schizophrenia. I'm just picking a couple. This was a study from the Enigma Consortium that was published a couple of years ago, involving almost 10,000 participants who were imaged. And what you're seeing, again, are these diffuse reductions in cortical thickness in temporal areas, parietal areas primarily. And then this is another imaging approach that you can get in vivo called diffusion tensor imaging, DTI. And what you're looking at here is at the integrity of white matter tracks. So this was a really nice study that came out a couple of years ago, much smaller N, but still quite informative, looking at white matter tracks in the brain in schizophrenia, and looking to see if there was a relationship between this measure of fractional anisotropy, which is basically a white matter integrity measurement, and severity of symptoms in schizophrenia. So in this study, what they found was that there was a relationship between fractional anisotropy in the arcuate fasciculus, which connects several regions of the brain, including temporal regions, to frontal regions, all of which had been implicated in the disorder. These connections are abnormal in schizophrenia and show a relationship to symptom severity. So just again, to give you a taste of some of the things we can do with imaging. Now, let's go back. I mentioned there were a couple of caveats with the genetics. One being, that these are clearly overlapping across disorders. But now let's drill in. This is the top hit, right? In the major histocompatibility complex, hugely statistically significant at this point. There has been, a lot of really elegant work looking at this genomic region, which is really dense and complicated, basically, to make a very long story short. And so what I'm about to show you, some of it comes out of now famous paper from Steve McCarroll and Beth Stevens from a few years ago, that tried to get some traction based on this GWAS hit and understanding the underlying biology. So that said, it's real important to remember what the effect sizes are for these individual SNPs. So in this case, for the MHC SNP, it's the A variant that is overrepresented in schizophrenia. 86.4% of people with schizophrenia have this version, and 13.6%, I'm sorry, 84.6% of people who have schizophrenia carry A, and 13.6% carry G. Again, I'm oversimplifying a little bit. What do you think these ratios look like in healthy individuals? 85% of healthy individuals carry the same variant, but don't have schizophrenia, right? Small, small, small effect size. All of these SNPs that come out of GWAS studies point to very, very, highly statistically significant, but very tiny amounts of signal individually in terms of genomic risk. That being said, if you put this together, as you can with these polygenic scoring methods, you start accounting for much more significant chunks of variance. So in 2014, we had about 18% of the total genetic liability for schizophrenia being explained by these variants, most of which are below the 5 times 10 to the minus 8 threshold. This is putting everything together. And again, this is a whole talk, but just to give you a sense of real progress, I think, that's coming out of these studies. Now, it's hard because these genes are, well, they do lots of different things, right? I showed you a couple that relate to dopamine and glutamate. Most of these hits, we have no idea what the functional implications might be. But at least we're seeing some proof of concept. So back to Steve McCarroll and Beth Stevens' paper. So let's draw a quick analogy. And I know we're running short on time, so I'll try to finish this part up quickly so we have enough time to discuss. How do you grow a forest? Well, what do you need for a forest to grow? Well, you need sunlight, right? And you need leaves because the leaves pick up the sunlight. They do their photosynthesis thing, that's really important. What happens if the forest becomes overgrown? Well, then you don't have enough light coming in, and the leaves aren't going to be able to do their thing, and so that's not optimal. What if you have too few branches? That's not good either. So there has to be a balance, right? And we can kind of think about synapses the same way, especially during adolescence. And here, what we're talking about, again, borrowing a concept that helps mature the brain, and a process that we think may be going wrong in schizophrenia. Now, pardon the cartoon. I made this for my medical student lecture just because at this point I was hoping they wouldn't be falling asleep during the lecture. But what came out of Steve and Beth's paper is so fascinating in how this MHC hit potentially relates to pruning. So this is your garden variety bug, which is trying to infect someone. And one of the ways that the immune system gets rid of this bug is through something called the complement cascade. So complement are these little molecules that go and tag themselves to the bacteria or the virus or whatever, and then along comes your friendly neighborhood macrophage who sees the complement and goes to town. So that's how the bug is tagged for elimination. But it turns out that a completely analogous process contributes to pruning. So here's a neuron. We're not going to kill the neuron. We're just going to remove some synapses. So the same complement markers are tagging these synapses for elimination by activated microglial cells in the brain. So now what's happening is you're getting rid of some synapses and you're preserving others. So C4 is one of these elements in the complement cascade. You can see it in the brain, as is clear in these slices from the paper. But fascinatingly, you see increased expression in postmortem tissue in schizophrenia. So connect the dots. You have this variant, which affects complement. You see increased complement in the brain in schizophrenia. You see accelerated cortical thinning, which may or may not be related to pruning. It could be in part. But all of a sudden, you're thinking about this on the level of multiple systems, starting with genetics and ending with a macroscopic process that we think is contributing to the illness. So very promising approach by pulling together all of these various different threads. I'll show another one. This is work by Robbie Mueller that was just published. Robbie is a psychiatrist at Mass General who's just finishing his postdoctoral fellowship. So Robbie is looking at a different GWAS hit in schizophrenia in this, this manganese transporter. This particular SNP is particularly interesting because it is a functional variant. It is coding. It codes for a missense mutation in the transporter that we know affects the ability of the transporter to do its work. And you see in people, this is data taken from the UK Biobank. You see in people who have this particular variant that translates actually into differences in serum manganese levels in the blood. And it also translates into a really fascinating observable phenotype in the brain, which you can get to using a combination of T1 and T2 weighted scans, where again, you're seeing the effect of genetic variation on brain structure in people based on what version of the gene that you have. So another terrific lead, because guess what? Manganese is targetable. You can give it to someone. And so as they actually did a small pilot study as part of this paper, which showed some interesting results with regard to, again, going back to this genetic variant. Okay, so let me wrap up. I said at the beginning I was going to give a little bit of a cautionary note. Here it is. This was a very elegant paper that was published in Nature a couple of years ago. And this is Brian Roth's lab, a fabulous group. They do great work with dreads and other receptor physiology. In this paper, they solved the crystal structure of the D2 receptor, which, as I mentioned, is the target of every single antipsychotic medication. And the science of this paper, as far as I can tell, this goes way over my head, but it seems to be pretty pristine. That being said, I worry a little bit about the interpretation. And apologies if there's anyone in the audience who worked on this paper or has been in this group. Again, I have nothing but respect for this work. But what I'm going to point out is the way that it was framed in the paper. Okay, DRD2 is the primary target for both typical and atypical antipsychotic drugs and drugs used for Parkinson's disease. Unfortunately, many drugs that target DRD2 cause serious and potentially life-threatening side effects due to promiscuous activities against related receptors. Accordingly, a molecular understanding of the design and function of DRD2 could provide a template for the design of safer and more effective medications. And then in the discussion, among the most serious side effects of antipsychotics are extrapyramidal symptoms. Consistent finding is DRD occupancy with more than 80% in the CNS is demonstrated by PET. Given recent successes in leveraging crystal structures of these compounds, we anticipate that DRD2, so the other thing they did was model its interaction with risperidone, which is one of the second generation antipsychotics. DRD2 risperidone complex will accelerate the search for novel antipsychotic drugs targeting DRD2. As a clinician, I have to disagree because, first of all, DRD2 is not the whole story and may only be some fraction of the story. But second, what happens if you provide a treatment that binds even more specifically to DRD2 than what we already have? Well, I think the concern is it actually might make extrapyramidal symptoms worse. So to the extent that this is an off-target effect of this class of drugs, while solving the receptor structure and then thinking of that as a way to design new therapeutics in general, I think is an incredibly important approach. In this case, I think it may be a little bit overstated because I think the disease is more complicated. And so the cautionary tale, and this is a clinician scientist who's criticizing a brilliant basic science paper. You could totally go the other way, right? As a brain imaging person, we get this all the time. Blobology, what does fMRI really measure? It's just cerebral blood flow. So how can you make serious conclusions about how the brain is working? I completely get it and agree with those critiques. But that's really not the point that I want to make here. The point that I want to make here is it takes a village. For example, when you put this kind of expertise together with translational neuroscientists and clinicians who can help focus where the action is right now. Yes, absolutely, we need better treatments for schizophrenia, but I'm not sure that the D2 receptor is the best place to look, given kind of what we are increasingly learning about the brain. Then we have the best chance of coming up with new treatments. And that's, again, why I'm thrilled to have the opportunity to talk to this group, which I think has a lot of expertise in basic science, and really excited about the possibility of pulling things together in ways that are greater than the sum of all of our parts, I think. And then this is the last slide. As far as I mentioned, we're trying to do this, practice what we preach at MGH, with this new birth cohort study that is enrolling women early in pregnancy, following them longitudinally, and then following pediatric outcomes, because the best way to do this is prospectively. But it also is incredibly important to have that bedside to bench to bedside pathway, which is what we're trying to leverage, not only to understand observationally what might be happening in the prenatal environment that confers risk, but also, like potentially folic acid and maybe other things, protects against risk. How can we develop those interactions by playing with it in the lab, growing out brain organoids, seeing what happens to those organoids, as they develop, plus or minus the interventions that we're curious about, and then plugging that back ultimately on a population level with clinical trials, implementation studies, et cetera. This is, each step here is incredibly complex and relies on a whole range of expertise. And we're lucky at MGH to have the makings, at least, of expertise in a lot of these areas to get started. So I'll stop there. Just a quick acknowledgement of for the people who contribute to the folate work that I mentioned briefly. And I'll stop there. So let me stop sharing my screen. I think we have at least a little bit of time, and very happy to take some questions.
Thank you so much for that wonderful talk. I think if people would like to type in their questions in the chat box or raise their hands, we can kind of alternate. So any takers, first questions? So if not, we can kind of, since we have a ton of questions submitted, I might select a few of interest. And so there's a question that was interesting, I think, about sensory processing issues and the neurobiology there. So this one was submitted by Austin and Lisa Goodrich's lab. So she said, I'm curious about current thinking on sensory processing issues, particularly in the auditory system. She's studying the development of auditory efferent projections into the cochlea, and is just asking, does the schizophrenic brain misinterpret autoacoustic emissions? Are there any hints that regulation of sensory input within the cochlea would contribute to auditory sensory processing issues or to hallucinations in schizophrenia? And I think it's just a topic of great interest, the auditory hallucinations. What is the mechanism? What do we know?
Yeah, great question. So, and as I briefly alluded to, this is one of those areas where you have different schools of thought. At the end of the day, I think, all of them are going to be contributing to, some core idea, but absolutely there is evidence for primary sensory processing abnormalities in schizophrenia, both auditory and visual. And, we can see this in, physiology studies that we do with evoked potentials in patients versus controls. We can see it in MEG studies. We can see it with imaging studies. There's another clinician scientist who is in our T32 fellowship, Bakhtash Babadi, who is looking expressly at primary visual processing, which itself has multiple levels to it, and trying to understand where the deficit might be using a combination of physiology, behavioral tasks, and neuroimaging. So yeah, there's good evidence for all of these things. And at the same time, there's a wealth of evidence pointing to abnormalities in association cortex that we can't ignore. Dorsolateral prefrontal cortex related to working memory abnormalities in disease is one of the classics. I think Bengdi Baran is one. So she worked with Dara Minoak. Their lab has studied antipsychotic mechanisms and their relationship to association cortex. So all of these things, I think, are contributing on some level. And look, it's not surprising. If you're starting with genetic lesions and I use that term loosely, these genes are expressed all over the brain. It would be shocking if the ultimate psychopathology that we're seeing does not reflect some combination of all of these things. But the nice thing about using primary sensory modalities as models is that they are a bit easier to understand than association cortex. They're easier to model than association cortex. So to get a leg up on what some of those fundamental processes might be, it's a great place to start.
Thank you. And so I think we just got a new question related to this from Akshay Jaggi. So, and a bunch more questions, let's see. So on the topic of auditory sensory processing, while we're talking about it, it seems like auditory hallucinations tend to be voices. Is that generalization correct? If so, why voices? Why not bird song or ocean waves or something else?
Great question. And by the way, when I mentioned, the delusion about the FBI or the delusion about aliens implanting microchips, that's not random. We hear a lot of that. There's no question that the content of these delusions and hallucinations is not random. And I think that points to just how specialized the machinery is that must be not working right. In schizophrenia, we can see things other than voices. There are visual hallucinations. Sometimes we see gustatory and olfactory hallucinations, smell and taste. When we see those latter ones, by the way, that's a bit of a tip-off that it may be something other than schizophrenia, like it could be some other brain lesion, temporal lobe epilepsy, or complex partial seizures. But yeah, visual and to a lesser extent auditory are kind of what we see most often in schizophrenia. And it is remarkable that it is a syndrome and it's not random. And we don't know why. That said, there are some interesting, and I think this gets at one of the other questions, emerging treatments involving neurostimulation that are showing some promise specifically for auditory hallucinations. It turns out that if you use TMS over areas of auditory cortex, then some investigators have seen some signal in terms of mitigating some of the auditory hallucinations. So it's gross. But whenever you get something that results in a phenotype change in schizophrenia, I think it's definitely worth paying attention to.
It's really fascinating. So I'll read out some more questions. So a question from Rachel Fox. Given the overlap in symptoms between bipolar and schizophrenia and the fact that individuals may receive various diagnoses across the course of their illness before they arrive at an answer, what do you think needs to occur at the phenotyping level to better differentiate between these disorders? Or do you see it as more valuable to evaluate symptoms separate from a DSM-5 diagnosis, like the positive and negative data analysis?
It's a great question. The answer right now is pretty straightforward, and I hope it won't be as straightforward as we continue. So the straightforward answer is DSM is the best we can do. Clinicians are still, provably better than imaging, machine learning, and anything else you want to throw from the world of neuroscience at a diagnostic or prognostic indicator. That's just the way it is. That said, of course, we all want biomarkers that will help us for both diagnosis and prognosis, and of course, for tailored, personalized treatments. The problem with schizophrenia and bipolar and numerous other related disorders is there just is a huge amount of symptomatic overlap. And, you take two patients with schizophrenia and have them evaluated by different clinicians at different times in their illness, they're very likely to arrive at different diagnoses. So it is an art more than it is a science. But the whole point of RDoC and other initiatives from NIMH is to determine what the building blocks are from the bottom up, so that we can use those in ways to develop markers that are more sensitive and specific. We're not there yet, unfortunately. But hopefully with the trove and wealth of data that we are now collecting across modalities in these huge population cohorts, we'll make some headway.
Thank you. So I'm going to check out some questions here. But I want to encourage people, if you would like to turn on your video and ask a question in person, you're welcome, or in person on Zoom, you're welcome to do that as well. So let's see. We have a variety of questions. So one on negative symptoms. Are the negative symptoms related to cognitive deficits in a statistical level? Are they correlated or at a brain level involving the same brain circuits? Would you expect a treatment that ameliorates negative symptoms might also work for cognitive deficits and vice versa?
Great question. That gets right to something that I glossed over too quickly in the talk, was the overlap between negative symptoms and cognitive impairment. There is some, and it depends based on which area of cognition you're talking about. Yes, I think arguably there is some overlap on the circuit level, especially when it comes to frontal networks that are clearly contributing to both. We just don't have the biological specificity at this point to parse that in a way that is more meaningful than yes. So, there's a 30% overlap between this type of negative symptom and this degree of cognitive impairment. Clinically, we clump them together because those are the ones that we can't treat with antipsychotics and that are responsible for, collectively the most impairment. But I absolutely did not give that enough of a discussion. I'm glad that you raised the question. Until we have better treatments, frankly, for negative symptoms or cognition, we're not going to know. That's the proof, right? If you give someone something that was developed as a negative treatment symptom and their cognition also improves, then, that's something.
Thank you. So another question about nicotinic acetylcholine receptors. So given the high rates of smoking seen in schizophrenia patients, is there anything known about how schizophrenia affects nicotinic acetylcholine receptors, or if stimulating those receptors in some ways helps with the symptoms?
Yeah, it's a great question and a subject of ongoing work in a lot of places, including MGH, where Eden Evans and her group is looking at this. The Friedman Lab in the University of Colorado has had a longstanding interest in this. So it is an interesting phenomenon, right? That patients with schizophrenia smoke much more so than the general population. And, is there some reason for that? And in particular, there is a question about whether it could be a form of self-medication with regard to cognitive deficits in schizophrenia. So does smoking allow them to have some degree of increased focus related to activity through that receptor? And the answer is quite possibly. So the problem is you don't want to treat it by giving someone cigarettes, right? You treat it by giving nicotine. So nicotine replacement therapy, or not it is replacement for people who smoke, but nicotine therapies are being widely studied at this point with regard to cognition and other outcomes in schizophrenia for that reason.
So next up, we have a question from Josh Sains related to the Roth study. So despite the famous D2 graph, some people have argued that efficacy depends on the ability of these drugs to engage multiple dopamine systems and even some serotonergic ones. Do you buy this argument?
I do. These are all very dirty drugs. So when I say they're D2 receptor antagonists, that's just the beginning, right? Dopamine, serotonin, histamine, norepinephrine, a whole trove of complex transmitter systems are targeted by each of these and in different ways. So what's admirable about the approach that they took is that they are trying to get as specific as possible, which is really hard to do when you have drugs that have affect as many systems as our current arsenal of antipsychotics do. But there's for sure evidence about and beyond effects of antipsychotics, evidence of serotonergic involvement in the disease. And hopefully we will be able to approach all of this going forward, with designer studies like that lab does, that give us a better degree of specificity than what we have. The whole enterprise of psychopharmacology reflects, to some extent, serendipity. Finding this compound has an effect. Interesting. What if we tweak this? What if we tweak that? That is not a very rational approach to drug design. And what we need, as I mentioned, are more bottom-up approaches that take our signals from what we're learning about biology and genetics, and hopefully that will get us to more specific treatments. And the other analogy I like is, going back to cardiology, is a treatment for hypertension, right? You have somebody who starts on an ACE inhibitor and does better, but then needs a little bit more. So you add a beta blocker, and then they're doing better, but you need something else. You put them on a diuretic, because all of these systems are targetable with relative specificity, and can have synergistic benefit. And it may be that, there is no single drug for schizophrenia. In fact, I kind of doubt that there would be, but rather some cocktail that has better specificity than what we can realize right now with our current drugs, where again, we see some synergistic effects.
Thank you. So then a question on a topic you touched on in the talk, maternal infection. So from Charles Jennings, regarding the prenatal risk factors such as maternal infection, do you know how wide or narrow is the temporal window of susceptibility? Might it be more precisely defined by new prospective studies, and might that give us clues to the fundamental developmental mechanisms? And are there prospective studies underway of mothers with COVID, which I think you started to talk about, 19 infection during pregnancy?
So I love that question. We have two sets of studies now. We have retrospective and prospective. For the retrospective studies, it's real hard to get much specificity in terms of timing during pregnancy. For the prospective studies, it's easier, but that doesn't mean that that's the way these studies are done. More often than not, you see studies publishing on prenatal exposure as opposed to first trimester exposure, second trimester exposure, third trimester exposure. The autism studies that I mentioned, it is, to me, a really interesting paradox that early first trimester is when this exposure to folic acid has its effect, when in early first trimester, there's not much of a brain to speak of. How could that be? I don't know. I mean, we can speculate, but absolutely. Think of it this way. All of those gene expression studies that we have data for now using brain tissue, by far the most dramatic changes in gene expression in the brain happen during fetal life. After fetal life, much less variation than there is. So we have to look very specifically at different developmental windows. My bias, which in part is informed by these folate studies, is that earlier may be more important. But certainly, you look at other exposures like alcohol exposure during pregnancy. Any time is not good, right? It just may be doing different things to the brain at different times. So absolutely, we must look at this prospectively in a way that is with higher temporal resolution than the field has been. And that is exactly the approach that we're taking with our studies at MGH. That's why we're enrolling as early in pregnancy as possible and phenotyping deeply throughout pregnancy, as opposed to treating pregnancy as a unitary entity, which it is not. And then specifically with regard to COVID, yes, as part of our studies, we are looking at this a few different ways. One, so our colleagues in OB have done miraculous work during the height of the pandemic. While they're surrounded with pregnant women who are in the ICU because they have severe infection, they were getting biospecimens. So they have biospecimens from a whole cohort of women during pregnancy. Those kids are now being able to be followed prospectively. We're just about to put an IRB protocol in actually to start following them. The first kids are now like 6 months. So it will be interesting to see if there's any neurodevelopmental signal related to that exposure. It's not Zika, right? We're not seeing any gross problems, thank goodness. But the kids do need to be followed. And the other way of thinking about that, frankly, is that while I am concerned about what the public health impact of this might be, I'd love to be wrong about it. But if it does have that kind of impact, it's also in a way an opportunity, because the floor of risk may be higher. There may be more exposures, not just related to infection and inflammation and stress, but the other things that we also know are not good, like obstetric complications and substance use during pregnancy, are still there as well. So there are going to be kids who have multiple hits, but there will also be, of those kids who have multiple hits, some of them will do well. That's who we need to learn from. Not just to be able to say, okay, these exposures are bad and confer risk. You can't do anything with that. You can't tell someone, you can, but it's meaningless. You can't tell a woman who's thinking about having a baby who has a strong psychiatric family history, try really hard not to have any obstetric complications. Try really hard not to be infected during pregnancy. You can't. You can't. So what we're looking for are things you can do. Folic acid at the end of the day may only have a small amount of signal, if it has signal at all. But that's the prototype. That's the kind of intervention that we know is safe and available and readily inexpensive. And if it has any level of benefit and has any effect in offsetting some of these, non-modifiable factors, then that's what we're interested in discovering. So that's why these birth cohorts, I think, can be so powerful.
It's really interesting. So we have a quick follow-up question on the question about the Roth study from Josh Sains. But if efficacy requires some lack of specificity, more specificity could be bad?
Yeah, good question. So we just don't know. Again, my bias as a purist is that it's better to know what you're targeting and to have control over what you're targeting. So as we discover not just how multiple transmitter systems are involved, but what receptors are involved and when developmentally during expression those receptors are important, that we'll have a better sense of what to target. The non-specificity of what we have, again, from antipsychotics is not by design. It's by the fact that these drugs were made the way that they were, and therefore, we're not designed to be, to have specific targets beyond like the key one, like D2 antagonism. So it's spaghetti for sure, and it's a humbling question. And it goes to show how much further we have to go. But again, my bias is the more specific, the better.
Yeah, so I realize we have a lot of questions in the chat, but I also wanted to go back to some of the questions people had submitted, some of the ones we were discussing earlier. So we have one question from Rick Bourne. The term schizophrenia, though often referred to as a disease, appears to be more like a syndrome, spanning a wide variety of different underlying etiologies. Has that recent bonanza of genetic association studies provided any guidance in defining the subtypes that might have pathophysiological and therapeutic relevance?
Yeah, great question. I would say we're not there yet. So when you take something like a polygenic risk score, and by the way, really important caveat, this is a disease that affects the whole world's population, right? What we know from polygenic risk score studies is how we're beginning to learn about the genetic architecture of these diseases in white people. It just doesn't apply, unfortunately, to the rest of the world's population. So that's the first, big caveat. The second is, we're still imprecise, right? We're still accounting for relatively small amounts of variance. There's still a lot of overlap. There's certainly no genetic test right now that is ready for prime time in terms of stratifying someone's risk or helping to differentiate if you have someone presenting in adolescence with non-specific symptoms, which direction are they going to go? That would be great to know because although these diseases share certain features, they do have different treatments, at least at this point. The other classic example is let's say someone presents with depression and you want to treat them with an antidepressant, but they also have a family history of bipolar disorder. And if you treat someone who really has bipolar disorder, but their first episode happens to be depression, and you would have no way of knowing that they actually have bipolar disorder, and you treat them with an antidepressant, guess what? It can flip them into mania if they have undiagnosed bipolar disorder. That's a great example of why we would love to know. Is this person more likely to fall into a depression diathesis or a bipolar diathesis? And we don't know yet, but we're getting better. It will continue to require larger and larger studies and more sophisticated ways of understanding the genome than we have right now. But like I said, it's an exciting time, and I think we are making headway. And I just gave a talk actually as part of a symposium on psychiatric genetics in the direct-to-consumer era. And on the one hand, the punchline was there's very little meaningful genetics in the, that you can get from 23andMe or whatever at this point, but there is reason for optimism. Another, good example, again, I don't know why I love cardiology so much, but there they are beginning to see meaningful relationship between polygenic risk for cardiovascular disorder and response to statin treatment, where those who have higher risk show, stronger response to statins. It's proof of concept, but boy, would I love it if we could use that model in psychiatry at some point in the not so distant future.
Yeah, thank you. So we have a ton of questions, but I think we're running out of time. This just shows us this is an area where we should probably do more programming. I appreciated how you highlighted the need for more interactions between basic science and clinicians, and I hope that we can provide more of that at our initiative. Thank you so much, Dr. Roffman. Thank you so much to all of you who joined and submitted questions and showed so much interest in this topic. And thank you to Adam Sajak, who helped organize this. And I just wanted to mention, for those of you who are interested in other 101 series programs, next week we have Alzheimer's Disease 101 with Dr. Sperling from Brigham and MGH. So please tune in for that. And please send us suggestions if you have other topics or ideas for us. So thank you very much.
Bye, everyone. Thanks.
Bye.